And ladies and gentlemen, as we are about to begin, we ask for continued cooperation this evening and wish you an enjoyable session. Please ensure that you are signed in with your full name, first and last name for record purposes. You can right-click on your name where there will be an option to make any necessary changes. Lastly, we would like to inform you that this event is being recorded for storage and archives. Therefore, to ensure the integrity of our production, we kindly ask for your video and audio functions to be turned off. Thank you once again for joining us this afternoon and for your cooperation. It is now with great pleasure that I hand you over to our technical officer, Vanessa Ramsram.
Okay, good evening, ladies and gentlemen, and a special warm welcome to our specially invited guests and colleagues from the Mona and Caveville campuses. I am Vanessa Ramsaran, Technical Officer of the Pathology Club of UE, and I will be the chairperson for this evening's event. I would like to thank you for joining us for our 16th installment of CPALMSI on breast pathology. At this time, ladies and gentlemen, I am privileged to be introducing the speaker this evening, Dr. Kerry Nagee, who will be sharing his wealth of experience and passion for pathology in a 45-minute overview of breast pathology. But before we begin, I will now give a brief background about Dr. Nagee. So Dr. Kerry Nagee attended the University of the West Indies, St. Augustine campus, where he completed his MBBS degree in June of 2007. After being an intern and then a house officer at San Fernando General Hospital, he then became a house officer at Eric Williams Medical Sciences Center. He then went on to complete an anatomical and clinical residency at the University of Florida, with the subsequent fellowships at Stony Brook School of Medicine and the University of Rochester School of Medicine. In 2017 to 2019, he served as a pathologist at both NexGen and Eric Williams Medical Sciences Complex. After that, he was the pathologist and laboratory director at Appalachian Regional Healthcare. Dr. Nagee is now currently an assistant professor of clinical pathology and laboratory medicine at the Indiana University School of Medicine, Indianapolis. He is also a member of the College of American Pathologists, the International Society of Breast Pathology, and a Diplomate of American Board of Pathology. Clearly an inspiration to many, we are all very honored, pleased, and privileged for him to be here with us this evening. And so, ladies and gentlemen, I ask where you are to welcome the very knowledgeable and most certainly the very passionate Dr. Kerry Nagee.
Okay, good evening, everyone. Thanks for that introduction. Are you guys hearing me?
Yes, hearing and seeing clearly.
Okay, trying to set up my presentation. Okay, all right, good to be here, and thanks for that introduction again. I want to start off by saying, you know, when I first heard about your group, I was very impressed. We didn't have a group like this in my time in medical school in Trinidad there. So I was very, happy to see that you guys showed an interest and, wanted to form this group. And I want to encourage you all to take full advantage of this group, not only in terms of the knowledge you might get, but in terms of your academic knowledge, but in terms of career guidance and stuff like that. I will offer myself to be of service anyhow you guys want. Any questions you might have, I'll be always open to answering them. And I'm sure that other people who are attached, other pathologists who are attached to the group would feel the same way. So yeah, just a background about myself, as Vanessa said, I studied at UE Trinidad. I did house officer there. I wrote my USMLEs while I was a house officer, and I was lucky enough to get into a residency, then did 2 fellowships, came back to Trinidad, worked for 2 years as a pathologist, and now I'm back here. So I think I could relate to you guys' position. About 15, 20 years ago, I was in medical school, and I was able to pursue my career, and I hope I can be of guidance to you all and offer my insight in terms of how to get into pathology, not only in the US, but other areas that might be open. just grab my phone here for timing purposes. Yeah, so obviously I can't cover everything in breast pathology in 45 minutes, an hour. So what I just chose some high-level topics that you guys would probably come across with. Of course, breast cancer would be there. We'll discuss breast cancer and two smaller benign lesions that are fairly common in the patient population. So I hope that you gain some knowledge from these, because you'll definitely come across these entities in your practice, either in pathology, or if you don't go into pathology, if in your clinical practice as a doctor, you'll definitely come across breast cancer when treating your patients. So just to reiterate how common and widespread breast cancer is, it is the most frequent cancer in women globally, about 2 million cases per year. It is the leading cause of cancer mortality in women. And mortality for breast cancer is actually projected to increase over the next 40 years. So as I said, all these figures just go to show that it's pretty common, and you guys will definitely come across breast cancer in your practice as a general pathologist. Basically, you'll see it almost every day. You'll get breast biopsies or some sort of breast specimen dealing with breast cancer almost every day of your pathology practice, especially. So how do we go about diagnosing breast cancer? So breast cancer is one of the most researched and studied cancers out there. It affects a lot of women, and the pathologist only plays a small, albeit important, part in the diagnosis and management of breast cancer, but it takes a whole team to be involved in patient care for breast cancer. So as you guys probably are well aware of, there are three main parts in the diagnosis of breast cancer. First, you have your clinical history, then your physical exam, or the patient might present on screening. So the patient might come in with a history of, yes.
I'm so sorry to cut you off. Are you sharing your screen?
Yep.
Oh, I'm sorry, we're not seeing it.
You're not seeing it?
No.
I see it. It came off. Are you guys hearing me?
Yes, we're hearing and seeing it now. Thank you. Sorry for the interruption.
Oh, you're seeing it now?
Yes.
Now is it full screen?
Not yet.
Seeing
Okay.
it now?
Yes, great. Thank you.
Okay, yeah. So as I said, the diagnosis, the patient might present with a breast mass, breast pain, or they might present for screening. Typically, screening starts in around age 40 by mammogram or ultrasound. So that's a typical presentation. Either they would complain of a mass or they would come through screening. And of course, your next step as a doctor is to do the physical exam. And then once you confirm a mass as a clinically suspicious mass, you move on to imaging, radiology. So the main modalities of breast imaging, especially for breast cancer, is mammogram, and in combination with ultrasound or ultrasound alone. Now, mammogram is more typically used in older women, I think over the age of 40 or 50, whereas ultrasound is favored in the younger population. I'm not a radiologist, but from my understanding, it has to do with the density of the breasts. Ultrasound is better in more dense breasts versus mammogram. It could give you false positive findings in denser breasts. So it is typically more used for the older female patients who have more fat and less fibrous tissue in the breast. So after there's imaging, you know, either the imaging would detect a mass or they would see something suspicious, not quite benign looking, but not quite malignant looking. The next step is where pathology comes in. So the next step would be either the radiologist or the surgeon would take most typically a core needle breast biopsy. And they may also take a biopsy of the needle biopsy of the axillary lymph nodes. Now, at the same time that they do the imaging, if there's clinically suspicious lymph nodes in the axilla, they may image the axilla, and if they're radiologically suspicious for being malignant also, at the same time, the radiologist may choose to biopsy those lymph nodes. The purpose of that is to detect if tumor has already spread to the lymph nodes, which would change the staging and which would change the management of the patient. So this is where the pathologist comes in. We would get the breast biopsy or the lymph node biopsy, and it would be our main job initially is to make the diagnosis either malignant or in some cases it may be not malignant. You know, sometimes benign lesions could present radiologically as suspicious, but it really isn't cancer on biopsy. So that's the diagnosis of breast cancer. I want to touch a little bit on the treatment of breast cancer now. The initial treatment of breast cancer is based on the clinical stage, the hormonal and HER2 status, and the menopausal status. And you as a pathologist would have a major role in diagnosing breast cancer and staging the tumor, giving certain parameters such as the histological grade, things like that. But what's very important from the pathologist's perspective is the hormonal and HER2 status. So you as a pathologist would actually carry out tests on the biopsy or the resection specimen for estrogen receptor and progesterone receptor and HER2. And depending on the results of these tests, these parameters would guide the treatment of the patient. So you could see the important role that the pathologist has in breast cancer treatment. We may not be seeing the patient, but the information we provide to the clinicians, the surgeons, the oncologists, etc., play a very important role in the management of the patient. So yeah, the options for patients to treat their breast cancer would be a combination of surgery, radiation therapy, chemotherapy, hormonal therapy, drug therapy, or immunotherapy. And again, I'd like to reiterate that all of these subsequent treatments, they depend on information that the pathologist provides on the type of tumor, the histological grade of the tumor, the presence of DCIS, the ER, PR, and HER2 status. All come into play in the decisions based on whether a particular patient should get surgery, radiation, etc. Breast cancer is a very biologically diverse cancer. As I said, it's one of the most widely studied and researched tumors. And even within one tumor in a single patient, there might be different subclones of tumor, different characteristics, different biology. Some patients have multiple tumors on one breast and the opposite breast, things like that. And the pathologist plays a major role in studying the features of these tumors and helps with the management in that respect. So I'd like to touch on this concept of the multidisciplinary team approach to the treatment of breast cancer. The pathologist is part of the team. I put it at the top here, but this is in no particular order. So research has shown that a multidisciplinary team approach to the treatment of breast cancer improves patients' outcomes, improves their quality of care, improves their satisfaction with their treatment, things like that. So this concept is most commonly studied in breast cancer, but it's been expanded to other malignant tumors, for example, lung and some GYN, other tumors like that. So what this multidisciplinary team consists of is a group of medical professionals consisting of most commonly pathologists, surgeons, radiologists, oncologists, radiation oncologists, a chemotherapy nurse, breast care nurse, or research nurse. So this group would meet either weekly or bi-weekly, and they would discuss most, if not all, of the newly diagnosed breast cancer patients under their care. And based on different parameters, they would discuss treatment options, opportunities for clinical trials, things like this. And the pathologist has a major role within this team because, as I mentioned before, the pathologist provides information that the other professionals here use to make their decisions. So, you know, we would, certain information that we could provide based on the specimen that we've looked at, when we provide this information to these other folks, they use it in their decision making and the subsequent care of the patients. This is just a schematic diagram here showing that, as I mentioned, all these members are linked in the multidisciplinary team. There's a focus on pathology here. We would focus on the morphological diagnosis of cancer, description of the histology and grading, the surgical margin assessment, lymph node assessment, and then molecular characterization of the breast cancer, estrogen receptor, progesterone receptor, HER2 receptor, and gene expression profiling. So this information we provide is used, you know, by all members of the team. Okay, so that's just a little background on pathology. To give you I want to give you an idea of you know, the workflow as a pathologist, or you know, what exactly goes on in the pathology lab. I don't know how much, you know, exposure you all have had to a clinical pathology lab within a hospital setting, but just to backtrack a little bit, you know, we've talked about the diagnosis. You know, the patient presents with a mass, they get a biopsy, they get imaging, they get biopsy, and then the decision is either made, most commonly, that they would have to have the cancer surgically removed. So the first part of pathology is the gross examination. And these pictures here, I just want to give you guys an idea of what type of specimens we get in the pathology lab. And gross examination is the first step in your reporting on breast cancer. Before you look at slides under the microscope, before anything goes on, you need to do a proper gross examination. So this first picture here is just a picture of a core biopsy specimen. As I said, when the patient presents with a mass, the radiologist typically takes a core needle biopsy. This container contains formalin as a preservative, and these little slivers of tissue, that's the breast tissue. So it's typically about 1 to 2 centimeters long. So you can see how we can make a diagnosis of breast cancer based on these small pieces of tissue. So that's your core biopsy specimen. Your two main options for surgical treatment of breast cancer are a partial mastectomy, also known as a lumpectomy, or a total mastectomy. So these are the two major types of specimens you'd get in the lab. So this is a partial mastectomy specimen. As you can see here, this is in the operating room. The surgeon has removed a portion of the breast tissue, which contains a tumor. And this is what we get in the lab, in the histology lab. It's a portion of the breast tissue. These are sutures here that the surgeon has placed to orient the specimen. so we could process it properly. And this is a total mastectomy specimen. Here, the entire breast has been taken out with the axillary tail. Typically, they remove an ellipse of skin containing the nipple and the areola. And this is the underlying breast tissue here. Skin would normally be here, but they left that on the patient. So I'd like to reiterate to you guys that as a pathologist, you need to use your eyes. So it starts with the gross examination. You look at everything, especially on the mastectomy specimen. This skin ellipse, you would look at, is there any obvious masses, discolorations, any ulcerations, things like that, because you use your eyes to decide what tissue you need to sample. Obviously, we can't look at every single thing here. But if there's an obvious lesion, you'd sample that lesion to look under the microscope. The nipple, you'd look at if there's nipple retraction, anything like that. This axillary tail, this contains the axillary lymph nodes. And this is the lymph node status is very important in breast cancer. Typically, the breast lymphatics drain into the axilla, and your breast cancer would spread to the axillary lymph nodes first. So in here, you would have your sentinel lymph nodes and other lymph nodes. So you'd also have to take samples from those lymph nodes if you do get an axillary specimen. So further into the grossing of the specimen, on this side, this is your partial mastectomy specimen. And if you guys don't know, but in the histology lab, sometimes we use a lot of ink. This is, we ink the surface of the specimen, especially partial mastectomy specimen. It's inked in different colors, each color designating a different margin. Now you'd ask yourself, why do we go through the trouble of inking these specimens? This is to ensure we examine the margins properly, because when we take these sections, the ink actually stays on these sections, and we see it under the microscope. And an important aspect of any cancer assessment, especially when it's resected, is to make sure that the tumor is not at the margin. The tumor has been completely removed, which is the aim of surgery. You want to remove all of the cancer from the patient. So this ink helps us to assess the margins on the microscopic slides and report to the surgeon that, okay, there's no tumor at the ink or the margin, so you've removed all the tumor. If there is tumor at the ink, we would see it under the microscope, and we could report that to the surgeon that there is tumor here. You might need to go back and resect more, or you might need to consider radiation therapy in the case of breast, things like that. So first up, we ink the outer surface, and then we make serial sections of the breast sample. Now, as you can see, most of the breast is yellow fatty tissue. And a breast tumor is typically, a little tan whitish in color with irregular borders. These metallic clips here are actually biopsy clips that were put there at the time of the biopsy. So you serially slice the entire specimen, and you look at each slice, searching for that firm, obvious tumor that you would sample. And these are tissue cassettes, these white things here. So you would take different sample sections of the tissue and put it into the cassettes, and these would be made into your slides, your microscopic slides eventually. This on the right hand side, this is a total mastectomy specimen. This is the posterior aspect you're looking at. It's been inked black, and again, you serially section it. And well, the skin would be on the anterior surface, so the slices would remain connected, but you go through each slice and you look again for that areas of tumor, firm white tumor, which is different from the normal breast tissue, which is mainly fatty yellow tissue with some white fibrous bands interspersed. These are just some high-power views of breast cancer. As I said, breast cancer has, this firm white appearance. This is your normal tissue on the periphery here. But breast tumors typically have infiltrative borders. It's invading into the normal tissue. This is another tissue this is some hemorrhagic change within this tumor here. So after we've done the gross examination, it's time to move on to the microscopic examination. So I want to review the basic histology of the breast, basic normal histology of the breast, because to know abnormal, you need to know what normal is, right? So you must know normal histology of every organ, basically. So the normal breast is composed of stroma, which contains collagen and adipose tissue. Then the cellular elements, it's divided into the terminal duct lobular unit, which is the functional unit of the breast. And then within that terminal duct lobular unit, there are epithelial cells, which are for the inner cell layer, and the myoepithelial cells, which are the basal or outer cell layer. So I'll show you these in picture form here. So this is your typical terminal duct lobular unit. So before we get into that, this pinkish stuff on the periphery here, this is your fibrous stroma. This supports your epithelial elements. This is your epithelial element. The terminal duct lobular unit, if I draw a line, it's like almost like a tree, with the trunk of the tree being the terminal duct and the branches being smaller ductules. And these lobules, this group of lobules being like the leaves and so on. So we have the terminal duct here and the lobules composed of acini. And if you remember the physiology of the breast, the purpose of the breast is to produce milk. So within the cells within these acini would secrete milk. They would go into the smaller ductules, eventually emptying into the terminal duct lobule, the terminal duct, sorry. And then it will go up to higher level ducts, eventually leading to the lactiferous ducts in the nipple, where the milk is expressed. Another point I want you to focus on here is notice how everything is fairly ordered. I could draw a line around here. There's order, there's no disarray in the structures. I can draw lines around the periphery. This is in contrast to a carcinoma, which has more infiltrative, disorganized growth in it. Now on to the cellular components consisting of the epithelial and myoepithelial cells. This is very important in the concept of breast cancer. So this is a higher power view of the lobular units. Again, the pinkish stuff is the stroma. We'll just focus on this one here. You can see a contrast between darker staining cells and paler staining cells. So the outer cell layer here is the myoepithelial cell layer. They are not always this clear, but they are always found on the outer layer. This is like your not basement membrane, but your barrier. If cells proliferate and begin to break this basal cell layer and they get out into the stroma, that's when carcinoma develops. So if there's a whatever, genetic process driving these cells to proliferate and become cancerous, they would break through the basal cell layer and become invasive out into the stroma. This is your inner cell layer or the epithelial cells. And again, based on various stimuli, these may become malignant, they may proliferate and eventually turn into ductal carcinoma in situ. These ducts become expanded and eventually they would break out and become invasive cancer. This is just an immunohistochemical stain. The brown stain is just highlighting the basal cell layer being intact in normal ducts. So that's just an immunohistochemical picture of the normal breast. So let's move on to breast cancer. So there are many histological subtypes of breast cancer. I'll just focus on the two common types today, which is invasive ductal carcinoma of no special type, also known as invasive ductal carcinoma, and invasive lobular carcinoma. But as you can see, there are many other types of breast, histological types of breast cancer listed in the WHO. So invasive ductal makes up about 80% of your tumor, of your breast cancers, invasive lobular about 15 to 20%, you know. So the vast majority are invasive ductal or invasive lobular. So invasive ductal carcinoma, what are the histological features of invasive ductal carcinoma? It consists of glands, tubules, sheets, or nests, or cords or single tumor cells which invade into the stroma. The tumor cells are pleomorphic and enlarged. They may have increased mitoses, and there are no myoepithelial cells present. And the stroma has a reaction which is called as a desmoplastic reaction, which is a reaction to the invasive tumor cells. I'll show you some pictures of this now. So this is invasive ductal carcinoma. Here we see these gland-like structures basically invading into the stroma. There's, if we go back to this picture, as I recall, there's order here. There's no invasive structures here, but here there's no order. There's glands infiltrating in different angles, different sizes of cells, different sizes of glands. Similar thing here, you see it's splitting the stroma here, so it's invasive. When you say ductal, it means gland-like. So it typically forms these gland-like structures. This is another view here again. There's no order here, it's just invasive. This is your pink stroma, and all these cells are invading. They're forming vague gland-like structures. So this is your typical appearance of invasive ductal carcinoma. And a similar thing here, invading into the stroma. And these cells are larger than normal epithelial cells. They've lost the myoepithelial cell layer. And they're very pleomorphic. In contrast, the invasive lobular carcinoma consists of discohesive small tumor cells with minimal atypia. The tumor cells would invade in as single file or linear files or narrow cords of cells. They may sometimes form a concentric pattern around normal ducts called the targetoid pattern. There may be no or minimal associated desmoplasia, and the main feature of lobular carcinoma is there's loss of the cell adhesion protein called E-cadherin. So you can imagine when you lose this adhesive protein, the cells dissociate from each other. They don't form nice tight glands anymore. And basically this is what invasive lobular carcinoma looks like. Again, your background pink stroma. But these are individual tumor cells, sometimes lining up in single file pattern here. So these cells have lost their cohesive E-cadherin membrane protein in the process of becoming malignant, and thus they don't adhere to each other. So they don't form glands or ducts, structures like that. They just invade as single cells going through the stroma. A similar pattern here, more single filing, some thin cords, and a higher power view here. That's a similar single file pattern of invasive lobular carcinoma. This is the targetoid pattern I referred to earlier. In the center here, you have an intact, preserved normal duct, but all around here, there's tumor cells infiltrating around the duct, giving you that targetoid pattern. So those are the two main types of breast cancer you'd come across histologically: invasive ductal carcinoma and invasive lobular carcinoma. I want to touch on the two aspects I mentioned earlier that are very important in terms of your role as a pathologist and how you contribute to care. That is testing for and interpreting the breast cancer biomarkers. Now, these biomarkers have implications on treatment for the patient, the prognosis of the patient, things like that. That's why they are so important. So the main ones we focus on right now are the estrogen receptor or ER, progesterone receptor or PR, and the human epidermal growth factor receptor 2, also known as HER2. So the presence of ER and PR correlates best with the patient's response to anti-estrogen therapy or chemotherapy. So if a patient is ER, especially and PR positive, their chances of responding to anti-estrogen therapy such as tamoxifen and some other newer drugs would be better. Of course, if they're ER negative, PR negative, they might be offered chemotherapy, some other chemotherapy agent, because their tumor is not driven by estrogen. Also, HER2 positive tumor would respond better to anti-HER2 therapy. You know, obviously, if your tumor has HER2 receptors on it, you would give it anti-HER2 therapy, such as Herceptin or some others. And that's the whole point of the testing. You don't want to give a patient a drug or a therapy that has potential side effects when they're not going to get any benefit from it. They'll just get the side effects and no benefits. So you as a pathologist are the one determining, okay, this is ER positive, this is HER2 positive, and then your oncologist would make the decision, okay, now I can give this patient this treatment based on what the pathologist reported out. So this is a picture of positive ER immunohistochemistry. So immunohistochemistry is basically a process where we use some antibodies which are colored, typically brown, that are directed against proteins on the cell surface, or in the case of ER, in the nucleus of the cell. So if a tumor, if an invasive ductal carcinoma has estrogen receptor in the nucleus, and we use this immunohistochemical agent directed against ER, it would pick up the stain and give you this brown color in the nucleus of the cell. So as we can see here, all, if not most, if not all of this tumor is positive for the brown stain. So it's estrogen receptor positive. It's a similar thing for progesterone. It's located in the nucleus, so you'd get strong nuclear staining in positive tumors, in ER or PR positive tumors. In contrast, this is a picture of a HER2 positive tumor. Now, HER2 is found on the membrane of cells. So the antibody directed against HER2 would localize to the membrane. So this is the circumferential membrane here. Here we have the nucleus, which isn't staining, but this is a HER2 positive tumor, and it's strong, intense staining on the membrane here. So this would obviously be reported as a HER2 positive carcinoma. So that's breast cancer in a nutshell, the two main types. I wanted to touch, if I have time, just briefly on two more benign lesions that you may come across in your clinical practice, in your clinics, in your surgical rotations, things like that, that you should also, be aware of. Not every mass in a female breast is breast cancer. There could be benign causes for it also. And the two lesions I'd like to touch on is the fibroadenoma and the Phyllodes tumor. These are placed in the broad category of fibroepithelial lesions, and they are typically benign. So fibroadenoma is the most common breast tumor that you'd find in adolescent or young women. It is benign in all cases. It's usually solitary, firm, well-circumscribed ovoid mass. So the patient would present with a firm, well-circumscribed, mobile mass, and you'll have imaging which would give you the similar features of a well-circumscribed mass. So this is your gross specimen here. This is a gross specimen of a fibroadenoma. These are typically easily excised or shelled out from the patient. As you can see, this is the entire tumor here. It has a well-circumscribed border. There's no attached breast tissue here because the surgeon was able to easily get in and dissect this lesion out. It's not invading and attaching to the adjacent breast tissue, so it's easily taken out. So it has a tan white, uniform cut surface similar to a breast tumor, but the difference here is that it's well circumscribed with well demarcated borders. So as I said, it's well circumscribed. It's a biphasic tumor, meaning it has two components. So it has a proliferation of both the glandular epithelium and stromal elements. And it's basically in the name here. Fibro means fibrous or stromal. Whenever you hear adeno, it means glandular or epithelial. So an adenocarcinoma is a gland-forming carcinoma. A fibrosarcoma is a fibrous sarcoma. So most of the time in pathology, if you just analyze the name of a lesion, you'll get a fair idea of what the tumor is. So the fibroadenoma is a biphasic tumor composed of a proliferation of both glandular epithelium and stromal elements. The myoepithelial cells are intact in the glandular epithelium, which is in contrast to your invasive carcinomas, where they are absent. And the stroma is composed of collagen and bland spindle cells. There are typically no mitoses, and there's no cellular atypia. So this is two pictures of a fibroadenoma. In between here, you have your fibrous tissue, which is more proliferative than normal. And here you have your gland-like structures, and they're typically compressed and become slit-like because of the expansion of the stroma. Similar picture here, you have your expanded stroma with your compressed glands or ducts here. So your fibrous or fibrostroma and your adenoma or glands here. So it's two components, glands, proliferating glands and proliferating stroma. The Phyllodes tumor is also a fibroepithelial lesion, but this one has a slight possibility of turning into malignant tumor, but the vast majority are benign. Over about 80% are benign. I have it down there. So Phyllodes tumor that presents as a firm mobile mass. They can be oval and lobulated. Again, it's a biphasic tumor composed of glandular and stromal components. And ultrasound is not reliable to differentiate between a fibroadenoma and a Phyllodes tumor. So on imaging, you can't confidently say that this lesion is a fibroadenoma or a Phyllodes tumor, which is why the clinician might choose to biopsy the lesion to get a diagnosis of either fibroadenoma or Phyllodes tumor. Because a Phyllodes tumor may require, well, it will require surgical excision, whereas a fibroadenoma, some, patients may choose to watch and wait approach and not excise it. Phyllodes tumor may require excision because, again, of that small malignant potential. So 75% of Phyllodes tumor are benign, 20% are borderline, meaning that there are some histological features that are not completely benign, and it may have the potential to become malignant. And then about 5% of these tumors are overtly malignant. And as I said, the treatment of a Phyllodes tumor is local excision with adequate clear margins. So these are pictures of a Phyllodes tumor. Grossly, it has a more lobulated surface here. This is some normal breast tissue. It might have a cyst lining. It might be in a cystic cavity. Again, similar thing here. There's some lobulations here as compared to the fibroadenoma, which has a more uniform, smooth cut surface. There's some cysts here, which you typically see in Phyllodes tumor. And histologically, you can see basically what we saw on the gross. This on the outer edge here, this is normal breast tissue, normal ducts here. This is your capsule. Oops. And here's your Phyllodes tumor. Again, you see a stromal proliferation and then compressed glands, similar to fibroadenoma. But the difference here is that the Phyllodes tumor typically has these leaf-like projections into these cystic spaces. Here you have these cystic spaces with leaf-like projections. And the Phyllodes tumor typically has a greater degree of stromal proliferation as compared to the fibroadenoma. In these tumors, you have to assess for things like nucleotypia, mitoses, necrosis, because these would indicate features that are malignant. So varying degrees of these features, the presence of varying degrees of these features would either lead to classification of borderline or malignant Phyllodes tumor. But if there's no atypia, no necrosis, no increased mitosis, it would fit in the category of the the benign Phyllodes tumor, which the vast majority are. Again, here's another picture of the Phyllodes tumor. Again, here you see more stromal overgrowth with some benign glandular lining here in that cystic space, forming these leaf-like projections of tissue. Okay, so that's it for the book knowledge part of my presentation. I wanted to spend a few minutes just on the journey of getting to become a pathologist. As I said in the beginning, I did my medical school down there in Trinidad, so I could relate to you guys in terms of what path you need to take in that respect. So the first step obviously is medical school. You need to complete your medical degree. I want to stress that to you guys. You've gotten this far. Sometimes it may seem difficult or hard, but you need to complete that medical degree because it's a step to everything else. And it may seem difficult, but most people get through it, and with some hard work and dedication, you get there. The next step, at least in the US system, is to get into a residency. So what about 15 years ago, I wrote the USMLE. I don't know, how much that's changed, but you need to take these entrance exams and do well on them, apply to different residencies. And all this information is available online. You guys could search, 15, 20 years ago, it wasn't as widely available to us, but there's a fair amount of residencies out there, and they do accept international medical graduates. You just need to find them, combined with your good scores and plus or minus experience in pathology. If you can show them you have interest in pathology, if you do some pathology related research studies, put that on your CV. All these things contribute to making yourself a better candidate to get into residency. So residency in the US is typically 4 years. It's combined anatomical and clinical pathology. Although some residencies allow you to do anatomical alone or clinical alone, but those are, on the lower end of availability. So a 4-year residency in anatomical and clinical. Again, it's tough. It's a tough residency. It's a big ask of your time, but the difference from medical school is you'll be focused on, you know, pathology. Pathology is a big area, big area. You can't learn everything from just a residency, but you know, you could focus, if you have a particular interest in pathology, you could focus on pathology, which is a good part of the residency. In the US, you get paid as a resident. You don't have to pay for the residency. There's no application fee or tuition fee or whatever it is. They actually pay you. It's not a lot, but they pay you. It's enough to survive. So after the 4-year residency, you have the choice of doing a fellowship. Most people do fellowships. There's a small percentage that don't do fellowships. But now with the vast majority of people doing fellowships, it's needed to get a job and so on. Most fellowships are typically 1 year long. Oh, before I go into that, at the end of residence, you'll have to take a certifying exam, the American Board of Pathology exam, which, you know, gives you the certificate that you've completed a residency. You could become a practicing pathologist at that point. But as I said, most people are going to do a 1-year fellowship. There are certain 2-year fellowships, I believe Neuropath and maybe 1 or 2 other things are 2 years, but the majority of fellowships are 1 year. And there's a lot of fellowships out there: Hempath, Dermpath, Cytopath, breast, surgical, almost any subspecialized area of pathology that you have an interest in, you can go do a fellowship in that area. So after a fellowship, of course, you become a practicing pathologist, and there's a lot of options as a practicing pathologist. You can be an academic pathologist, work in a residency program with a mix of clinical work. You can become a full clinical pathologist, just go out and sign cases, you know, not involved in research or teaching or things like that. There's research-based pathologists. Some people actually work with these biotech firms and drug development and things like that. So there's a lot of options out there. There's even now a branch of pathology called informatics. If you have interest in computers and coding and all these things, you can actually apply that to pathology workflow in the lab, workflow in histology, to come up with ways to improve the pathology lab just using data and coming up with computer software and things like this. It's a big area. You can go into research, discover different things, patent it, things like that. So there's a lot of options as a pathologist. And I'd like to encourage those of you all who are interested in pursuing it as a career, you know, to keep up that interest. As I said, to use myself and others in this group who are already pathologists to guide you and offer advice, and you know, be open to asking questions and finding out as much as you can about pathology. I mean, some of you all will decide not to do pathology, but it's good to be part of the club and get some pathology knowledge. You'll use it in your clinical practice. So I encourage you all to continue participating in this club. As I said, I'm very impressed with what you guys did and the things you all have been doing. So I'm always available for questions. I'll leave my email with Vanessa or someone at the end. If anyone wants to email me questions, that would be fine. So thanks again. And I'm open to any questions right now.
Okay, so Dr. Nagee is ready for questions. If you'll have any, you can type it in the chat, or you could raise your hand and I'll allow you to just put on your mic momentarily. Dr. Nagee, if you don't mind, in your USMLE overview there just now, you would recommend that we complete our MBBS degree first, because I know from other talks, most would recommend that we do step 1 in year 3. Or from personal experience, do you think it will make more sense to complete it first?
Yeah, so how I did it was I did it after I graduated. Of course, this was 2007, 2008, so it's about 15 years ago. Over that 15 years, I don't know how things have changed. It is, I mean, looking back on it, it is possible to do your step 1 after your clinical years. But I did it, you know, after my training, but it is doable, I would assume, to study for your clinical years and study for your step 1 at the same time. Sorry, your preclinical years studying for your step 1 at the same time, because there should be a lot of practice material out there, online question banks, things like that. There were a few in my time, but I don't know how much it's increased. But if you could get access to those online question banks, there's a lot of YouTube videos now. You know, the information is out there. You just have to search for it and find out, you know, good resources. And it would definitely be doable in my mind. Either way is fine. I mean, I did it afterwards. It's either way is practical in my view.
Okay, thank you so much for that. I have some questions here, if you don't mind. One of it is, can you tell us why you specifically chose breast pathology and what or who inspired you to do so?
Oh, that's interesting. Well, breast pathology, as I said, it's very common. So during my training, I always had in my mind that I would return to Trinidad and practice for a bit. And in Trinidad, you know, you have a general pathology practice. It's not really subspecialized. So as I said, breast pathology is something you'd see commonly. And so I wanted to focus on an area that, you know, improve my skills in an area where it's very common. So I'll be very proficient in that area. So that was one of my main driving aspects. And as I said, it's a very well-studied field. It's very scientific once you get into it. So that was my main motivation for getting into breast pathology. I didn't have any particular person who inspired me actually to get into breast pathology.
Okay, great. Well, your presentation was very thorough, so I only have one more question for you at this time. You mentioned quite a staggering statistic about the increase of breast cancer, I believe was within the next 40 years, you said, right? So where do you see the field of breast pathology itself in the future?
Oh, in the future, I think it'll still have a major role in addition to everything I mentioned. You know, we're getting more into testing of the behavior of breast cancer. So a big area now is assessing the likelihood that breast cancer would recur in a patient after they've had surgery and therapy. So there's new tests like MammaPrint, Oncotype DX. So that we're getting a lot into the molecular aspects of breast cancer, subclassifying breast cancers into different molecular subtypes, which the aim of all that is to help develop specific targeted treatment for these breast cancers. So pathology will continue to have a role in especially the molecular aspect and developing that in the regard of how do we best treat breast cancer and how, you know, what are the new drugs and things like that we need to develop, and giving the patient an idea of their prognosis in terms of, you know, what is the likelihood that this tumor might recur 5, 10, 15 years down the line.
Okay, great. Well, that's all the questions I have for you at this time. If you'll allow me to share my screen.
Yeah, that's fine. What do I need to?
We sent a live feedback link for persons to describe how they felt about the presentation. Some of them were educational and clear, well detailed, thorough, very helpful, interested, intriguing, pockets of knowledge, simple, eye-opening, refreshing, inspiring, I believe, great, nice. So we have lots of nice feedback about the presentation. So thank you very much.
Okay, thank you.
Okay, great. Now I would just like to deliver the vote of thanks. So I hope you all had a wonderful and learning experience. So at this time, the feedback form link has been sent, and we would like you to take a minute to fill it out. It will be greatly appreciated, not only for documentation, but for improvements to our future events. So if you'll allow me to start with a quote, Deepak Chopra once said, "Gratitude opens the door to the power, the wisdom, the creativity of the universe. You open the door through gratitude." So firstly, I'd like to thank our feature speaker, Dr. Kerry Nagee, who, despite his busy schedule, graced us this evening with an amazing and enlightening presentation where we were all extremely grateful to learn about breast pathology. Last but not least, ladies and gentlemen, I would like to thank you all for accompanying us tonight and making our event a success. And we look forward to your continued support. To all of our UE students and staff across the 3 campuses at the University of Ottawa and Eastern Ontario Laboratory Regional Association, and especially to our specially invited guests, thank you, thank you, thank you. So ladies and gentlemen, this marks the end of our session this evening. So thank you very much again for joining us this evening for our 16th installment of CPALMSI, and we hope that we see you at our future events. Good night, all.
Come on.